So we're honored to have Dr. Feldman join us today. She's Associate Professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School, where she's co-director of Ambulatory Gynecologic Oncology and director of the Center for Pre-Invasive Disease of the Lower Genital Tract at Brigham and Women's Hospital and Dana-Farber Cancer. She oversees multiple research projects on cervical cancer prevention, sits on numerous national committees, and we're so lucky that she made time for us today. Because she's such a leader in cervical cancer prevention nationwide. So I'm going to turn it over to Dr. Feldman.
I'm going to say thank you so much for inviting me and including me in this. I'm going to talk today about primary screening with HPV for cervical cancer. Why are we changing to that way of screening, and how are we going to do it? So this particular talk was put together through through a group that I'm working on, and actually both Team Maureen and Nancy Peña are also working with the American Cancer Society to help people throughout the United States roll out primary HPV screening. And so as part of my role, I'm helping to create educational materials, and this talk we're going to give today is part of that. So I'd also welcome any feedback people have about how helpful it is. So my disclosures are that I sit on many guideline committees. I don't receive any money for these services. I also write the cervical cancer screening chapter for Up to Date, and those are my only disclosures. I'm hoping that after this, you'll be able to understand sort of how much HPV is out there and how it affects all of us, and why that's important, and how that's going to be relevant to implementing the new guidelines in cervical cancer screening. So, as you may or may not know, although cervical cancer isn't as common a cancer in the United States, it is the fourth most common cancer among women globally, with more than 500,000 new cases every year, and around 342,000 deaths. Most of the new cases are going to occur in low and middle income countries. And that's not just important because they occur in those places, but also important to us, as immigrants from those countries will probably not have been screened when they arrive in the United States. And so those are a particular high-risk group. Now, vaccination against HPV combined with screening and treatment is actually amazingly effective at preventing cervical cancer. But in order for it to work, all of our young children, so children ages 9 to 12 ideally, should be vaccinated. And then all appropriate people need to be screened and treated before they get to cancer in order for it to be effective. As you all know, there are two human or HPV types, HPV 16 and 18, which are responsible for about half of the high-grade cervical precancers. Both of those two HPV types are included in all HPV vaccines. So HPV vaccination historically was two HPV types. It was 16 and 18 plus non-cancer causing type 6 and 11, which cause genital warts. Now the HPV vaccine has 9 types, so it will always have 16 and 18, and then it will have the additional 4 types that are the next most likely causes of cervical cancer. Basically, we want to get that vaccine into all young people before the onset of sexual activity. Now, sexual activity is important to understand that it's skin-to-skin contact, not necessarily vaginal intercourse. So anybody who has skin-to-skin contact, regardless of with whom or how they exactly have that, is at risk for HPV. Most male or men also have HPV at the same rates as women, which is 80 to 90% of the population have a high risk subtype, but more than 90% of them will clear the infection. And the other thing that's important to know is women who are living with HIV or immunosuppressed women, so that could be kidney transplants, that could be people with lupus, RA, inflammatory bowel disease, any of those sort of autoimmune illnesses are more likely to get cervical cancer compared to immunocompetent women. So the WHO had put out in November 2020 a target of eradicating cervical cancer, and that meant that 90% of I just want to say this is the WHO's wording, 90% of girls were fully vaccinated with HPV vaccine by age 15. And of course, they're focused on cervical cancer. We want 90% of all children vaccinated because oral pharyngeal cancer is also caused by HPV, and it's actually growing beyond cervical cancer in the United States as an epidemic cancer among men. 70% of women should be screened with a high performance test by 35 years. And again, by 45, that's globally. We're going to talk specifically about the United States new guidelines in a second. And then, of course, we want 90% of women who have precancers to be treated. So let's talk about in the United States. So screening has been very effective. In fact, cervical cancer screening is the most, hold on a second. Is the most effective screening test ever performed. And as you probably all know, initially it was the Pap test. And you can see here in 1975, when the Pap test was first really started in the United States, screening rates, cervical cancer rates were high, and they came down dramatically. And this chart shows us down towards 2007. However, you can see on the bottom, it's a little hard to tell in the chart, but the rates of cervical cancer differ among different groups. And you can see the light gray are Black patients, and the black line with like dark circles are the white patients. And you can see the rates were lower among whites versus Black. The current rates are closer among everybody, in the sense that, screening has worked for everybody. But there are certain groups that are still not as likely to get screened. And that may be Black women, or I use this term over here, PWAC, which is patients with a cervix, to include transgender men. And so in all of these categories, that would include those people and people who live in rural areas, obese women, LGBTQ women, or transgender men, immigrant patients, older patients. And by older, we're thinking about people near the end of screening, so 60 and above, people who don't speak English. And of course, there's much intersectionality here. So many people belong to multiple of risk groups, which further exacerbates the likelihood that they don't get screened equitably. This is a study from the National Health Interviews Survey, which found that the percentage of women who were not up to date with screening is actually getting higher, not lower. So it was only 14% in 2005, and now it's 23%. We believe that's partially because the screening guidelines are more complicated. As you all know, it used to be that everybody got a Pap every year and evaluated for any abnormality, and then in around, I think, 2002, we went to every 3-year PAPs, and there have been many subsequent guidelines that have made it more and more complicated. And I think, therefore, it's harder for people to comply with guidelines. That being said, as you can see here, patients, from certain groups are really disproportionately affected. The most disproportionately infected, of course, are uninsured patients who only have a 42% non-screen rate. Rural women are more likely to be non-screened, and non-Hispanic Black a little bit more. But I'd say the really big issue, of course, is uninsured patients. So I wanted to just focus a little bit on the type of tests. I know that many of you know these, but I want to sort of talk about why they're the pros and cons. So this on the left is a picture of a Pap test, and you can see that what it is we've scraped the cervix, and the cells have been spun down and put on a slide, and the person reading the slide is deciding how many of those cells look abnormal. And based on that, you can see on the right, if the cells have very big nuclei, that's the center of the cell, and the cells are small, that's more likely to be a high-grade abnormality to the right. And if the cells are very pale and have little teeny nuclei, then that's more likely to be normal. And so the person reading it is sort of judging, it's a little bit of an art, not a science entirely. Is it more likely to be towards the right over there, the CIN3 or high grade, or are the underlying cells that the smear represents more likely to be normal? And so it's sort of a guess because it's just a scraping. And you can imagine that that means that it's not that sensitive. By that, I mean is that it can miss things because it's sort of a guess, and you have to also make sure that the right cells have been sampled. So the HPV test, however, This doesn't mean you have a precancer. It means that a patient has an active infection with an HPV virus. And an HPV virus, if it hangs around for a long time, is more likely to result in a precancer. So this test has a high sensitivity. What that means is it's going to pick up everybody who's infected actively with HPV, although it may not tell you if those people actually have a precancer. And so here I want to show you a picture of an HPV infection. And what you can see is that the HPV infection is not all superficial. So I don't know if you can see can you see my pointer here? Anyways, here's where we're going to be taking the sample from. And if it's an inactive HPV down here, we're not going to get a positive result, right? It's not until it gets all the way, and you can see it going through the phases here, all the way up here, where it's the terminally differentiated keratinocytes. Those are the ones we're scraping to get the result. And you can see here that this cell is putting out active HPV virus cells. That's what we're picking up. So what we're sort of telling is in the test is that there are active cells that have HPV in them, and that those HPV viruses are replicating. That's sort of what we're telling, but we can't tell for sure that the cell is, let's say this cell, which may have already changed, or this cell that's beginning to change and isn't that seriously changed. So it doesn't tell us exactly what's happening. So we often, and for the past, I'd say 10 years, have been relying on both of the tests together, a Pap test and an HPV test on one sample. You can imagine that it gives you the information as to whether they have an infection actively, which puts them at risk, and also whether or not they have precancers. The problem is it does result in a lot of unnecessary testing, because remember, every single time you do the co-test, you're getting two tests, and either one of them can be abnormal. And so that results in more colposcopies, which, as you know, creates both cost to the patient and a lot of extra stress and anxiety. So we don't want to do, although it is a little bit more reliable in picking up a precancer, we don't want to do excessive burdens of colpos to patients who may not need them. So they've sort of updated the screening guidelines with that sort of thought process in the background. So not everybody qualifies for routine screening, however. So if a patient has prior abnormal results, we don't even include them in screening. So that would be surveillance. Surveillance testing is sort of a new term we use in cervical cancer prevention, and it means following up of people who've had prior abnormal results. In order to determine if somebody has prior abnormal results, technically, you're supposed to get their records to confirm there's all normal results before assuming she is low risk. But we all know that in actual practice, that's very unrealistic. And so if they have an unknown prior risk, you don't have their records, you don't know what their records are, they came from another country, whatever it is, then they're considered unknown risk, and they actually immediately get screened. So that people with unknown risk are screened. The only people who are considered low risk screening are those who you have documented normal results, and if they have prior abnormal, again, they're called surveillance. If somebody has bleeding, even if they've had recent testing, you can get a Pap or HPV. If somebody has another HPV related dysplasia, they also might get more frequent testing, and immunosuppressant patients have their own guidelines. So again, to define this better, screening is testing for disease among patients with no symptoms and all normal prior results. Surveillance is interval testing among women and people with a cervix who have a prior abnormal test result or have received treatment. And as I pointed out, the unknown history may fall in between. And so if you don't know their history, you have to sort of consider them higher risk. And then diagnostic testing means a patient has symptoms, even when they're not due for a Pap. So this is a slide to show you that HPV is better at predicting your risk of dysplasia over a period of time than a Pap, which is also known as cytology. And it's really the persistence of the HPV infection that puts you at risk. So on this graph over here, on the vertical axis, you see the cumulative incidence of severe dysplasia, or CIN3. And along the horizontal axis is the years since enrollment. And if at year 0, you test positive, you're HPV positive, this is the blue line, you can see that your risk of developing severe dysplasia over 5 years is 7.6%. So it's a very good predictor of will you develop high-grade dysplasia. You may not have high-grade dysplasia now, but it's a good predictor that you will in the future. The black line shows if your PAP's abnormal, and you can see that at the very first test at time 0, the PAP's a little bit more sensitive for picking up high-grade dysplasia, but it falls off in sensitivity over the 5-year period and actually misses almost half of the severe dysplasias as in terms of predicting that they're going to occur over that 5-year period. Conversely, a negative PAP, which is the dotted black line, gives you a 5-year negative predictive value of 0.36%, but a negative HPV is even more reliable for reassuring you over 5 years, as it's about half the rate at 5 years of 0.17. So in either case, the positive HPV was more predictive of disease, and the negative HPV was more predictive of no disease at 5 years. Now my slides are not moving, sorry. And it does matter what type of HPV you have. So as you can see in the green, the HPV 16s are the worst type. And so people who at time 0, they have a normal PAP or ascus. They could have either ascus or normal. And the cumulative incidence rate, and this is done in months over here. You can see that it's 17.2% with HPV 16. It's 13% with HPV 18, and the 12 other high-risk groups are much lower, as you can see here. This is just also pointing out that in the HPV vaccines, as I mentioned to you before, HPV 18 and 16, which are the turquoise, are the most common causes of cancer. And so combined, they're about 70%. And then the other types that are covered in the non-valent vaccine, which are represented in gray, are going to add up to about another 20% altogether. So this covers about 90% of cancers. So why do we want to move to primary HPV screening? So the first is what I just told you, is that it's more sensitive for picking up CIN3 over time than a PAP alone. It turns out that adding the PAP and the HPV together does not significantly affect your risk of your ability to predict cancer. The other nice thing about primary HPV, which is not FDA approved for yet, but is very appealing in many settings, is the idea that patients could self-collect, because the HPV test doesn't have to collect the cells right on the cervix. It just has to collect cells that have fallen off from the cervix and are infected with HPV. And so that could dramatically improve the patients who are willing to have testing and also could get testing. The disadvantages is it's not as specific, so it doesn't always tell you if there's an abnormal precancer there. And of course, it requires integrated infrastructure. In other words, if somebody is self-testing, or if you're doing a swab, you have to, even clinician approved swab, you still have to have integrated infrastructure to bring people back for the next step if there's an abnormal result. So that would be the colposcopy. So this is just comparing the 3 options, which is comparing precancer development for women who had a negative cytology test over 6 years, which is the highest rate. That's the purple. And you can see that if they had a normal a normal HPV or a normal HPV and co-test, there was a slight advantage of having the both, but pretty much they were in the same range of risk. And so that's why we're considering HPV alone sufficient, really, for a screening test. Of note, though, for primary HPV testing, you cannot use just any old HPV test. There are only 2 FDA-approved HPV tests. One is the COBIS and one is the BD on Clarity. One of the silver linings of COVID was that most labs now have a Cobus machine, which isn't a very expensive machine, because it's the same machine that was used for COVID testing. And that turns out to be an enormous upside, unfortunately, of COVID, that we now have these machines all over the world, where we almost didn't have them anywhere before COVID. So it makes the opportunity to do primary HPV testing much more realistic. So when you get a primary HPV test, when you get a primary HPV test, you're going to do it on the same thin prep or SurePrep sample or whatever. You're going to do it on the same sample, and it will automatically give you pooled results for, first we'll say pooled results HPV positive, and then it will give you whether there's 16, 18 present, because that's really important for management. HPV 16 and 18, as I've said many times now, are the most important. And so we always want to know if an HPV test is positive, if in fact it's positive for 16, 18, because those are managed slightly different. So the current algorithm is for patients who are offered HPV testing, which would be for patients 25 and over. So it's not going to be offered in this setting for women under 25. It's going to be HPV testing. Simultaneously, it will tell you if it's positive for 16 and 18, or for 16, 18, if it's 16, 18 negative for the 12 other high-risk genotypes. If you do primary HPV testing in the 25 and over group and it's negative and they have no history of abnormal results, so this would be just for low risk people who are all normal, in their past history that you've documented, then they get follow-up in 5 years. If it's 16 or 18, or if it's 16, 18 negative, but the 12 other tests positive, then it's going to be reflex cytology on the same specimen. So no need to bring back the patient for another visit. And then depending on whether they have 16 or 18 present, if they do have a 16 or 18 present, they have the option of immediate treatment with LEAP versus colposcopy for high grade. And if it's less than high grade, but 16 or 18 positive, you also have that choice of colposcopy or LEAP. If the PAP is normal and you're HPV positive with 16, 18 negative, then the patient would get a follow-up in 1 year, similar to what they would do with a co-test. And otherwise they get colposcopy. So self-collection is not yet FDA approved in the United States. There have been a lot of studies in many, many settings that have shown that it's effective, it's cost effective, and it's also acceptable to many of the underscreened populations, particularly rural women, LGBTQ people, and the sensitivity has been thought so far to be comparable to clinician obtained samples. So what do you do with abnormal results? It's very similar to the prior guidelines. And you're looking for creating a risk profile using the ASCCP app, or there is also a free version of the app, which you can get from asccp.org. And you're looking at patients with persistent HPV as the highest risk group compared to patients with a new infection. And so you want to know what their prior results were if you have them. And the individual patient risk estimates, which will be the combination of their age, their HPV status, their HPV 16, 18 status, and their cytology status, as well as their prior history, is going to determine what you do next. This is giving you an example of why the prior risk matters. And so this is the immediate risk of CIN3 for a patient who has an ASCUS HPV positive, conditional upon what their prior history is. Suppose that their prior results were all normal and now they have an ASCUS HPV positive. You can see that their risk of CIN3 is very low, 0.9%. If they have a previous HPV positive, but the one before that was HPV negative, and they now have a risk of about 5%. If they are HPV positive previously or thought to be or unknown history, then and now have an Ask Us HPV positive, that's 7% risk. And if they've been treated for high-grade dysplasia in the past and they now have an Ask Us HPV positive, you can see that their risk of CIN3 at the moment is 12%. So people are concerned, will we miss cancers? Most cancers are caused by HPV, and the HPV test has been shown to be more sensitive to pick up cancers than cytology alone. And as you know, Q3-year cytology is sort of our gold standard, and we've been okay with that for many years. Will colposcopies increase or decrease? I think that's somewhat unclear because the percentage of younger women who are getting vaccinated may actually block a lot of the 16-18s as well as the other types covered in the 9-valent vaccine. And so maybe we'll actually go down in the number of positive results. And of course, many people are worried that will patients still see their providers, and that is a legitimate concern. But as we know, there are many other reasons that patients need to see their providers, and we need to emphasize the other aspects of well women care. So to just summarize, HPV is the most sensitive screening test. Screening only applies to asymptomatic women with an all normal documented screening history. The thing that's highest risk is when you have persistent HPV, especially if it's with 16 or 18. The best references and easy to get are to go to www.astcp.org, and you can purchase a phone app for about $10, or you can actually just request an online free app that will allow you or your clinic to calculate the risk management plan, and they send that to you. Thank you.
Thank you, Dr. Feldman. We have a question from Jackie. The question is if the HPV PCR test is a cytology sample or blood?
You know what? Hold on one second. I want to just exit my talk so I can see everybody. Just a minute. So I'm looking. So the test is how do you take the test? Is that the question?
Yes, correct. If this
okay. Yeah. So let me ask you a question, Jackie. What type of cytology do you do?
We are public health. I'm just learning about this. We don't treat patients or see patients. We don't, but I just wanted to know in the.
Okay. So cytology or pap smears were historically done. You took a scrape from the cervix and you put it on a slide. And then now maybe 20 years ago, we changed that to something called liquid-based cytology. So we take a jar, we take the smear from the patient's cervix the same way, but we actually put the cells into a jar of liquid, and that liquid is spun down, and they then plate those on a slide for the cytology, but they can use the same liquid to do the HPV test. So we basically are recommending that people take it in the same way as they have been doing the cytology in the liquid-based specimen, but request the HPV test be done first with reflex to cytology, meaning they do the HPV and only do cytology if the HPV test is positive.
Thank you so much for the clarification.
Thank you, doctor. And I also have a question. I know that we discussed that so many times, but when do you think then the self-collection is going to happen in the United States, and why it's taking so long?
So I sort of have two answers to that. I ask that question every single time we have these national meetings. And what I've been told all along is that it's because of COVID, that they have to approve it. And I guess at the FDA, basically they have so much stuff with COVID they've had to approve that they haven't had time to do it. So that's what I've been told all along. I think there's a little bit more complexity because I think they're starting to show the other. So let me go back a second. As I told you, there's only 2 FDA approved HPV tests, and those would be primarily what we'd want to use for self-testing as well. But the people who put out the RNA test, which is a different type of HPV test that we're not allowed to use for primary HPV testing, that's not been as sensitive. So they don't want people to start allowing people to do self-testing with that RNA test. So I think there's some complexity about whether it's safe enough to allow people to do if they're going to use the wrong HPV test. Does that make sense? So bottom line is, I hope it's soon. We're planning for it to be soon in our clinic because I think that's what we should be doing. but we can't do it until it's available.
Thank you so much, Dr. Feldman, for presenting for us today. And thanks all of you for taking time to join us. We're going to move from Dr. Feldman's big picture about cervical cancer and HPV and screening into narrowing the focus more on just the communities of Lawrence and Lowell and the project that Nancy and I worked on over the last 6 months or so. So as we mentioned at the start, the project was funded through Dana-Farber Cancer Institute's community benefits, and the goal was to reduce HPV and HPV cancers by improving knowledge and people's willingness to educate within their community about HPV. So to do that, Nancy used the NPI Navigator model to train 4 community leaders in Lawrence and Lowell about HPV, HPV cancers, screening for HPV cancers, vaccination, and navigating the health systems. And then all those trainings were done completely in Spanish, and all the materials were in Spanish. And then those community leaders then hosted their own training sessions in their communities, all in Spanish for Spanish-speaking residents, and included the content that they had been trained on with Nancy. So that project went through the spring. We had 94 participants in the community sessions. They all completed surveys, and the range of age was 16 to 81 years. All but 5 of those people were in Lawrence and Lowell, and 87 of them were women. Of course, all of them were Spanish speaking, as we mentioned. And you can see on the right the country of origin for the participants, the largest number of which participants came from the Dominican Republic. So that survey asked a number of questions, and we're just going to highlight some of them here. One of them was, when did you last have a Pap test? And, let me find my cursor so you can see. So the top 3 are not necessarily the most helpful, partly because we don't know what risk people are at and what their screening requirements are. So they may only be scheduled for screening every 3 years. So this doesn't necessarily mean that they're following the guidelines or not following the guidelines. But hold on. But then, but these 2 on the bottom are particularly interesting. So 13% of the participants in the community groups said that they had never had a Pap test, and another 13% reported that they didn't remember if they had or didn't know. So this is a huge opportunity to screen people who are either previously screened or maybe being screened and don't even know what they're being screened for. We also asked about the barriers that people encountered when accessing their medical care in Lawrence and Lowell. And they are, most of them are things that you might expect. The greatest number of participants said that the fact that they didn't speak English really impacted their ability to access care, with 40% of respondents saying that. And then far less said that it was actually because the clinic didn't have interpreters. The next highest categories were in lack of transportation and then other. And so for the other, we unfortunately didn't have a free response to find out what all those were. We did get some comments at the end that told us a little bit about what some of the other categories were, but this is just a space to remember for any future projects that we should be allowing people to fill in some of those other categories. The next highest for barriers to care were, we think, quite related. One is that the clinic didn't have hours that worked for me. That was 16% of respondents. And then another 11% of respondents said that I can't take time off work. And we're thinking that those 2 are particularly related. So we share this with everyone so that as you're thinking about how to reach more community members and screen more people and decrease the disparities between non-English speakers and English speakers in cervical cancer screening, these are the additional pieces to consider. So like for Dr. Feldman's clinic, we know that transportation is something that they already address by providing means for transportation to their clinic appointments, and just considering different ways to address these barriers when serving clients. This was a really interesting one that I included because I think it's really hopeful. So we asked whether or not, and I should say that all these questions were asked completely in Spanish, and Nancy was kind enough to translate them for us so we could present them here today. We asked whether or not people asked questions at their medical appointments, and overwhelmingly for people who did make it to a medical appointment, even if they had a language barrier, they still did ask questions at their appointments. A very few number reported that they either don't ask, are embarrassed to ask, or feel like their doctor is too busy to ask. We also asked about information provided at the clinic about the importance of having a Pap test or HPV test or the HPV vaccine. And by a smaller margin, but 44% of respondents said that they are not offered information about Pap testing, HPV testing, and vaccine. That doesn't mean that they're not being screened. It's just that there's not a dialogue about the importance of these, of HPV's connection to cancer, or of the availability of the HPV vaccine to prevent cancer. So this is an important one because it demonstrates to us that there is a huge possibility, huge potential for educating more about HPV and its connection to cancer, and that information for patients who are there for potentially a cancer screening could trickle down, and they'll recognize the importance of having the HPV vaccine as a preventative measure for for young people and their families. And then we followed this question by saying, well, would you like someone at the clinic to educate you about Pap testing and reducing cervical cancer, including HPV? In that, and overwhelmingly respondents did say that they were very interested in having someone in the clinic, in that clinical setting, providing them with additional information about these topics. So we see a large gap on the last slide of how many people were getting information about HPV and cervical cancer at their medical appointments, and then their following interest in having that. So we know that there's a huge possibility for education in the clinic because people are receptive to that, even despite language barrier. At the end, we asked for additional comments, and these were some of the comments that were shared. Some highlight the barriers that we already discussed. I don't understand the health system in the US. I have difficulty with technology was an additional comment that probably fell into that other category, especially as medical appointments can be made online now. It can be really challenging if technology is a barrier. Of course, I don't speak English, which we saw from the barriers, and I can't take time off work. But we also saw that the community education sessions that we hosted were really well received, and definitely filled a gap in educational availability. So the comments included that it was an excellent talk. I didn't know anything about Pap smears, but I learned a lot today. And that with what I learned about HPV, I'm going to be able to help my family get vaccinated and educate my friends. One person said, thanks for the session. Now I can pass this information on to my family so my sisters can vaccinate their children. And one person was very clear in stating that she would get her children vaccinated against HPV in the following months. So not only did we collect some really interesting information, but we now know that this model of having navigators be trained in HPV and cervical cancer to educate in their communities in people's first language can be a really effective way of sharing information about HPV and cervical cancer.